Thank you very much, Peter. It's a great pleasure to be here. I have appalling stage fright whenever I come in front of an audience which knows a lot more of the subject than I do, which is about every time I address an audience, so I'm kind of used to the feeling. Although I'm a NED at Royal Papworth, that is, by the way, I'm not speaking in any capacity on their behalf. It just happens to be the reason I got interested in certain things. As a NED, I'm supposed to work about 4 days a month, supposedly. I worry about, among other things, the junior doctor's mess, paying the bills on time, surgical mortality, infection control, property valuation, productivity, the patient record system, executive pay, inequality, nurse-patient ratios, just about everything. And I don't know very much about any of it, is the truth. That's strangely comforting, actually, because it feels much like being a journalist. Where you similarly don't know very much about anything, but you pretend that you do. So it's perhaps unsurprising, I think, that being ignorant is becoming, well, it's not an area of expertise exactly. That would be a little weird. But it's what I want to talk about anyway, how ignorant I am about the job that I do and why. And particularly the data that are missing. So from a demand perspective, Peter, that's what I'm about. I'm a demand perspective. This is what I want. This is what I need from, hopefully one day, from people like you, and what at the moment I can't get. So we'll begin with this idea of dark data. It's from a book by David Hand, which I recommend, Why What You Don't Know Matters. I'm sure some of you will know it. He begins with an example about the Challenger space shuttle. 1988 now, can you believe? Still so vivid, the images of that explosion. And the reason was that there were distress in these so-called O-rings, little rubber rings, you know, that seal components of the shuttle. And there was speculation that problems with these things was linked to the cold. And it was a very cold day. It was about 2 degrees centigrade that day. But they plotted the data for what they call O-ring distress, and they found no relationship with temperature, and they launched. There basically was no relationship. What's the dark data? Well, the data when there was no O-ring distress. And you're kind of saying, well, you know, why are you interested in no O-ring distress? Because that's nothing happening. And actually, you're very interested in nothing happening because that's actually the outcome you want. And when you put in the data, which includes nothing happening, the relationship suddenly becomes quite clear, I think. Possibly some people disagreeing with me here. I think it's pretty clear, particularly when you plot 2 degrees C on that. That's about 35 degrees Fahrenheit. It's pretty much in line with the vertical axis. And the investigation afterwards concluded that under those circumstances, in that temperature, some catastrophic O-ring failures were almost a certainty. So that's dark data. And I think it's fairly clear that data analysis, no matter how sophisticated, machine learning, whatever, AI, can be worse than useless if you don't have the relevant data or you don't look at it. They had it, they didn't look at it. Silly little example I came across working for the Winton Centre when I was writing a blog. This is David Spiegelhalter's outfit for Risk and Evidence Communication, where I'm a board member and occasionally contribute. I go in and cheer them along. I don't actually do much analysis. And okay, the standard question, how much is 31% increased cardiac arrest risk? Because 31% of next to nothing is still next to nothing, so you want some baseline data or you want some absolute numbers. This is basic stuff. But there weren't any, either in the news reports of this or in the paper itself. There were no absolute numbers, no baseline data. So I thought, oh, well, that's all right. I'll go out and get some cardiac arrest data. That should be pretty straightforward. We must have some incidence data for cardiac arrests in the UK, so I could work out what 31% would mean as the number of bodies, you know, or the number of incidents. And you could look at the ONS data, but that's going to be for mortality, and you're not only interested in mortality, you're interested in the people who live with a cardiac arrest, who survive it, and so on. Probably some wry smiles around the room now as people think he wants to go out and get some incidence data. So I called the British Heart Foundation, and they said, yeah, really interested in cardiac incidence data. In fact, we're hoping to get some together before very long. And you mean there isn't any? Well, kinda, you know, one or two studies here and there. I said, okay, well, I'll try and have a look at some of these studies. And I found this one, eventually, after a little bit of trawling around, that the incidence of out-of-hospital arrests is about 60,000 a year. So ballpark, let's take people over 50, assume not too many arrests under 50, about 25 million people, roughly one arrest per 400. That's annually, and this was for a 30-day period, this paper, so divided by 12 gives us about 1 per 5,000. So our 31% increase, the risk rises from about 1 per 5,000 to about 1.3 per 5,000, and that's the 31%. And you think, okay, well, A, why am I doing this? I'm an English graduate. This is a ludicrous state of affairs that I'm kind of scrabbling around and doing my own calculations to work out. When people are talking about banning a drug, we're going to have this conversation without knowing the magnitude of the effects. It's a slightly absurd conversation, I think, that we have no basic baseline for this thing. I don't know. I mean, maybe I was looking in the wrong places. I'm not very informed about this. Maybe everybody knows roughly what the incidence numbers are, so you can just assume it. We're talking to familiar people, but not in the independent, I don't think, not when policymakers and others and regulators are getting involved. I suspect not. I suspect they don't know. Anyway, I don't know if you'd call it dark data, but the difficulty of finding basic numbers. I mean, incidence of cardiac arrests. Come on. Hopefully it's changed since I tried to look. Another quick example, this is Winton Centre again, the PREDICT system. It's an online tool helping people think about their treatments after they've had breast cancer. Adjunct treatments generally is what we're most interested in. It was developed by Paul Farrow and others at Cambridge University. Winton got involved because they redesigned the site and communication graphics so it could be used in conjunction with patients to help them think about their therapy choices. It now, worldwide, about 30,000 users a month. So we're quite proud of this at Winton. And so what's the dark data? Because basically we have this presentation of survival curves. If you look up there, you can click on the menu at the top, to present the data in chart, text, icons, tables, whatever. However people find it most congenial, most understandable, we can adapt the data for you. But there is a dark data problem here, and the Winton team wrote about it in this paper. They said it quickly became apparent that users would want to evaluate an increase in survival against the potential for side effects. You think? Well, you reckon? They seem to, They seem to want to know about the side effects as well. Unfortunately, so I'm missing a slide, I'm missing a line there from that slide. Unfortunately, the side effects data wasn't in any sort of state that we could make use of it. Basically, there isn't any usable side effects data. How do you take a decision? I mean, we're working on it. We hope that very soon we'll be able to put that data into the model and people will be able to make those comparisons. But let's just say some of those survival curves trade off. And there are points where it wouldn't make sense anymore under any circumstance because there's a negative utility, 3 years out or something like that. We don't know. We don't know. And this tool is used 30,000 times a month and everybody says it's wonderful and we think it's great. But there's this kind of huge piece of data that's just missing. This is not in a usable form. I mean, I'm kind of utterly bamboozled by this. It's 2023, this is 1980, maybe, this is 2023. Anyway. Oh, here we are. Our recommendation to provide the downsides is not something we could implement in PREDICT. Breast cancer is a quantitative data on the probability and severity of side effects. It's not readily available. Little digression on risk. because there's a long history of risk and it's quite entertaining. And there is a view that we've become much more sophisticated about risk, although I remember talking to the anthropologist Mary Douglas, who once told me, you know, the instincts are pretty much the same. And I think, you know, there's an idea that we began with a pretty primitive notion of risk. You know, either you're lucky or not, the gods favor us. There we go, hurricanes never strike our island, we're blessed, you know, it's just that sort of sense that I've got a bit of data, but it's only my data, you know, it's only my individual experience, or, you know, something like that, I don't have any general data, very naive view, but gradually we progressed, we understood, you know, we had conversations between Pascal and others, you know, worked out a bit of probability theory. We saw patterns in the data, you know, and we began to think, you know, there are general patterns here that we can observe. And then we started to say things like that. You know, here's a pattern in the data, oh my God! And then we got more sophisticated. Well, we didn't at first. We do this kind of thing as well. This is my favorite kind of stupid headline from, and you see the little fella down in the corner who's really sort of fed up with this, you know, is the next stage of sophistication, because say, oh, for goodness sake, can we have some absolute numbers, which is me being smug, you know, and trying to run more or less for 5 years and thinking, oh, for heaven's sake, you know. And then we get really clever. We have polygenic risk scores, board assurance frameworks, AI model, prediction models, and all this kind of stuff. And, you know, we understand it all now. We're on top of this, on top of the risk. And here's a board assurance framework. I see a lot of these kind of things. This isn't ours. I see quite a lot of these. Now, it's a story. When I arrived at Papworth, it was just moving into a new building. Absolutely fantastic facility. And, but there was one little problem. All the critical care beds were single rooms. From an infection control point of view, absolutely fantastic. But the nurses arrived on the wards and they said, even though they'd had a hand in designing this thing, they said, actually, it's not quite so easy to look across the bays and survey what's going on. You know, you can't get that kind of quick check when a machine starts beeping over there. You know, what's going on? Oh, that's fine. You know, you can't do that. You have to go out of the room, you have to do all your hygiene stuff, you know, you go into another room, you check, you know, all takes time. So they said, we think this is a safety risk. Because given the number of staff we've got, we can't quite get around so many patients as we used to. We need to restrict the flow of patients coming through the hospital. So the hospital agreed to do that. I think probably it was the right decision because we had to take the nurses with us at that stage. Take all the staff with us. But my question was, how did I know that restricting patient flow wouldn't do more harm through delay than the increased risk of not being able to see people as well as we could see them before? How do I know the balance of those risk trade-offs? Now, if I go back to any kind of board assurance framework or any risk framework anyway, I have data coming out of my ears about internal safety metrics. Number of times people fall, the number of red flags in critical care raised by nurses because there's some stress in the system somewhere. The number of complaints. We survey patient experience. The number of patient incidents, mortality outcomes, of course. All these internal measures of quality and safety. As I say, voluminous. You know, when we have these board assurance frameworks which you know, often which pick up on those individual risks, they give them scores, they give them these traffic light ratings and all this kind of thing. Now, it's watched like our institutional life depends on it, this stuff, which it probably does, frankly. We'd be slaughtered if we let it slip. Compare that to our information about people outside the building, waiting. Just about all that I know about people waiting outside the building is how long they've waited. And that's about it. Just lately, we've started doing systematic harm reviews, or trying, although don't have great confidence that they're telling us very much. And yet in that time, that waiting time, what might happen? You know, we talk about it as responsiveness. We don't talk about it as safety, but there's very clearly a safety implication of waiting. Are their outcomes going to deteriorate because they're longer on this list when they finally get around to having the op? Are there certain ops that we're just not going to be able to do because their frailty has gone up, so we have to do something inferior for them? Are the long-term survival going to go down? Are they going to pick up other problems? What happens to their mental health? What happens to their family? What happens to their job? We just don't know almost anything about this. There's been one or two little studies, again, trying to sort of say, well, if you do CABG, coronary artery bypass grafts, how many people die over what period of waiting, and you can try and extrapolate a little bit from that. But I look at my board of risk assurance framework, and I have almost no data about the risk consequences of waiting. I have a ton of data about the risk consequences inside the building. Why this distinction? Here's just another one. With its lovely calculations of consequence versus probability, 4 times 5 gives you a total number. All this veneer of sophistication, and it is useful. It is useful. But it just seems to me that about half of the whole responsibility is not there in the data. Now, what are the decision-making consequences of that for me? Well, it's just very, very hard to take decisions about what kind of priorities I give to speed getting people through, given levels of quality. Now, could it be possible? Now, I'm just guessing here. I don't know who to ask. But is it possible that we could have a look at all the kind of marginal gains on quality that we get, which are time-consuming in hospital processes, and strip some of them out in order to get people discharged faster, say? Just kind of talking off the top of my head. Don't know. But at the moment, we're not really looking because we're so worried that if we do take away any of those marginal kind of safety improvements, we'll get clobbered. Something will go wrong and the coroner will be on us. Or, the CQC will be on us. Because we have this massive infrastructure all bearing down on internal quality, internal quality, internal quality. So there are no incentives, there are no structural incentives to try and do the risk trade-off, at least not for us. There is, at the moment, I think, a bit of an increase in interest in whether excess mortality might be linked to NHS throughput. That has increased recently in the past, and I think it's a good thing to see. But again, curiously, the warning that came down to me recently, from somebody at regional level, was the danger that hospitals will become so preoccupied with getting the numbers through that there's a risk of another mid-staffs. That's how it was put. Be careful, we don't want another mid-staffs. Internal, internal, internal. So my argument then is that a system that often talks as if it's drowning in data is almost a data desert on one of the most important measures of its performance. And there's a slightly siloed or localized view of what kind of performance matters, the internal. I mean, how you justify a distinction between patients according to whether they have or haven't walked through the door, I don't know. I mean, naturally, I sort of phoned David and asked, come back to that one in a moment, phoned David and asked, how should we think about this? And he said, well, it's basically simple. I say, what's the denominator? What's your responsibility? What's the denominator? Is it people in the door or is it people outside the door, when they're referred? Well, it's got to be all of them. They've got to have moral equivalence, haven't they? They're all people with problems. How do you distinguish between them? Outcomes on the waiting list should be as important as outcomes after admission. But if I go back to my board assurance framework, is that evident from the data that I can see? No, it's not. It's kind of dark data. So we come back to my little risk thing, where we start off naive because all we're doing is depending on a little bit of localized data. And we have our risk sophistication where we have our board assurance frameworks. And we find out actually that little localized siloed data is still the way that we approach risk. What do we do about this? That's tricky. That's really tricky. And it's not easy to collect the data. It's not easy to know what kind of data it is that you need. You'd have problems like the moral injury that you might cause to nurses by saying you must not concentrate only on the patient in front of you. You've got to think about other patients. Now, in practice, everybody, of course, is in a soft way, thinking about other patients waiting, needing for treatment. Our consultants are thinking about that. Surgeons think about it. The management think about it. We're all trying to push productivity as hard as we can. But we just don't have the comparable data. And I suspect if we really had good data for the total effect of waiting, it would knock all the incidents that occur inside the hospital off the park. I think it would be so big, so severe, that we would look quite dramatically differently at the balance of our attention and our resources when we're thinking about how to run a hospital. But I don't know. I don't know. Okay, let's spin on. I'm just going to spin over breast cancer as an illustration, because I want to just spend the last few minutes testing you, see your own reactions, okay? Because here's some raw cardiac surgical mortality, right? Okay, and it's gone up. And you think, well, how much mortality is there? Well, there's enough for that to be a significant difference. And you start thinking, ooh, now how do you feel? How do you feel? Do you feel defensive? It's your hospital. Do you feel anxious? Is it, oh God, I have raw hospital mortality? No, you don't. You probably think, well, is it case adjusted? Don't you? Is it adjusted for the acuity? So you go to Euroscore, and the Euroscore case adjustment for the acuity mix. Euroscore, for a great matter of pride for Royal Papworth, because it was devised by Sam Nasheff, who's one of our surgeons leading like that. And you see that actually the death rate, the predicted death rate, has gone up substantially. So how do we perform against the predicted death rate? Better. Who feels a sense of relief? Because the question is, why? More people are dying. I felt a sense of relief when I looked at that data. And one of the things we were able to say is we don't think there's any unique local problem. But there's sure a hell of a problem. Mortality rates from surgical mortality for us now up around 3%. Used to be 1.5%. Almost all to do with rising acuity, we think. And we think we're actually doing better given the level of rising acuity. Now, hang on to that sense of relief, because I think it's really good indication of how the impetus to gather certain types of data can be a bad thing. Because what we're basically using here is the acuity as a way of letting ourselves off inferior outcomes for patients. We're actually using case adjustment, which is a very smart thing and a very necessary thing, as a way of us absolving ourselves of the wider responsibility to the whole patient community. And I think, I don't know how you feel about that, whether you recognize that sort of sense of localism about the way that we think about these things. But it implies, again, a kind of massive dark data problem. And it applies that our own instincts and our own incentives are running contrary to widening our view about what kind of data we look at. I've been a NED now for 4.5 years. I've got about a year and a half to go before they kick me out. And the ignorance is really coming along nicely. I've got to say, I think by 6 years when I finish, I'll be able to say that I don't know anything whatsoever. And that'll be something of a triumph, unless you lot can help me. So there's the invitation, there's the demand side, Peter. So thanks very much indeed for your attention. Pleasure to be here.
Thanks ever so much. Really interesting and a good challenge and call at the end. I think we probably have time for one question, if that's okay. I don't know if anybody wants to... Oh, hi. Yes.